Go ahead and share my screen. Welcome to our May 23rd, 2025 Project Echo Dementia session. I'm Chris Rhodes. I'm a neuropsychologist and professor here in the Department of Neurology at the University of Washington, and have had the privilege of being the co-lead of this project since we launched back in June of 2020, coming up on 5 years, hard to believe. We'll work through our usual kind of formats. Here's our agenda for today. Some very brief opening notes and reminders. We have a smallish group so far. People will join kind of as the session goes on, as is always the case. But we'll do some introductions. It's always nice to know who's with us. And then we have the great good fortune of an outstanding didactic. I've had a chance to review the slides. From one of our own community members, Dr. Silvia Russo, who also did a fantastic didactic back in March as part of our dementia primary care focused summit through the Dementia Action Collaborative. And Dr. Russo has been so kind as to also prepare a case that is congruent with the topic at hand. So that's always appreciated. And then we'll have plenty of time for a discussion as well. And given the complexities of Lewy body and Lewy body spectrum diseases, I'm sure there'll be plenty to talk about. All right, so a couple of reminders. If possible, if you can rename yourself so we can keep track of who's here for CME and other attendance purposes, just your first name, last name, and maybe clinic if possible. Looks like everybody is muted, which is great, and practice saying your name when you unmute. If you can turn your video on, that's always appreciated, but we realize it's not always possible. And then, in the rare circumstance that there's more than one of you in the same room, please let us know who else is with you. Some CME related information. If you are an affiliate of the University of Washington, here is the process. So texting this number to that number will get you CME credits. I think you have about an hour either side of the session to do so. For everyone else, we will keep track of CME through the usual process, and that's part of where having your names and info is handy. CME can also reach out if needed. Let's see, just some reminders about some other CME accredited series and educational opportunities. Our sister ECHO program for geriatrics, which is the third Friday of each month, interstitially between our sessions. A few of the other ones here that we've discussed in the past. We're interested to have some of our colleagues with other ECHO series come and do some presentations. So we're reaching out to our HIV colleagues and maybe diabetes to talk about the relationship between those conditions and cognitive health. Always happy to hear your suggestions as well. Some consultation options and repositories of information. Boy, if you're looking for something, you can usually find it in one of these two Grand Rounds archives. I want to remind you all, whether you are at an FQHC or a rural health clinic or have colleagues who are at FQHCs or rural health centers, we are accepting applications for participants, a care provider and some other member of the team who would enroll in this program for a year, either Project Echo or Cognition in Primary Care or both, and would do kind of a deep dive into our top 10, take post-tests, agree to implement the EHR toolkit, participate in the fantastic trainings, the 3 30-minute trainings that are part of Cognition in Primary Care offered by our own Dr. Gaster, and then some very limited, low bar, not a heavy lift data collection, just to take a look at practice transformation and impact. We're offering up to $8,000 for participation in both. Here's the QR code, and we're accepting applications through June 30th. So really pleased to be able to offer this in partnership with Department of Health in their BOLD grant here in the state of Washington. I am also pleased to report, now that the governor has signed the budget, that we are funded for the next 2 years. We were unsure that was going to happen, so fortunately we're sticking around. Case presentations, such a vital part of our learnings and always an opportunity to really translate what we talk about the didactics into pragmatic and practical practice transformation. So we will look forward to soliciting some cases and trying to keep that as low bar as possible. So that, some reminders, PHI, we always do our best to protect that. All of our sessions are recorded, although I just heard from someone that there's some dead links. So we will investigate that and make sure that everything's available, including all of the resources, which is another nice part of that repository. So anything that we've talked about is available there. And then of course, 1 minute post-session survey. We are accredited for CME, no disclosures, either our presenter or the planning committee. Here's our team, who, if you've been part of our community, you know as well. Here are most of you. I'm realizing we're also missing a couple of dots from some early participants, but really just, again, fantastic to see the breadth of locations and just the amount of expertise that is represented by each of these dots. Fantastic group to bring together this year's. And with that, I will introduce our presenter for today, Dr. Silvia Russo, who is a behavioral neurologist at Providence over in Spokane. And Dr. Russo completed medical school in Italy, and I would not dare try to pronounce the name of your medical school. I would not do it justice. But I can with confidence say that you completed an internship at Dignity Health, and then your residency and fellowship at Stanford, and have been over in the Spokane area serving patients and families there, people living with dementia and families there since July of 2022. And you have been such a wonderful participant and part of this community, and we are so fortunate to have present our didactic case today. So without further ado, I will let you take it away.
Thank you so much for that very kind introduction. I'm always happy to come to these meetings. I think they help me get connected to all of you and see the various perspectives. I'm going to talk to you about dementia with Lewy bodies and give you a bit of an overview of what that is and what other similar diseases are in the setting of that group. I think it's a very common disease and oftentimes seen even in primary care. So we'll go over some aspects of the disease from the pathology to the clinical criteria to the management, and then we'll try to apply these to a case that it's a real life case that I have in my clinic. Facts and terminology. Lewy or dementia with Lewy bodies is a synucleinopathy. What is a synucleinopathy or synucleinopathies, plural? It's a group of neurodegenerative disorders. So they're progressive disorders caused, as far as we know, by either the loss of function and or the accumulation of alpha-synuclein in the nervous system. It's the second most common group of diseases after Alzheimer's disease-related disorders. The age of onset is between 70 and 85, but it can be early onset. Again, oftentimes it presents together with Alzheimer's. It's more common in men, but from some newer studies I was reading, women can have atypical signs, and so it can sometimes be missed. There is a lot of terminology around the synucleinopathies, which can be confusing, but different names mean different things. So when you say Lewy body dementias, this is an umbrella term that includes both dementia with Lewy bodies, which is the main topic of this presentation, and Parkinson's disease dementia, which we'll see is when dementia occurs in an established diagnosis of Parkinson's. And then dementia with Lewy bodies is the specific subtype where dementia occurs concurrently or before the onset of movement disorders suggestive of Parkinsonism. Whereas Parkinson's disease dementia is when the dementia starts 1 year or more after somebody has well-established Parkinson's. And so this is quite confusing, but when we say dementia with Lewy bodies, we mean when the dementia is the first sign, whereas Parkinson's disease dementia is dementia within an established Parkinson's. Then you have mild cognitive impairment in Parkinson's disease. That means when Parkinson's patients have some cognitive difficulties, but they do not quite meet the criteria for dementia, which is loss of function. When you say, and this is where the complications start, Lewy body disease, this is something you see under the microscope. So dementia with Lewy bodies and Lewy body disease are two different things. So Lewy body disease is the underlying pathology that you see under the microscope for all of these conditions. And then there are new terms in the DSM-5 that are used to distinguish and establish these diagnoses. These are the fancier terms, major and mild neurocognitive disorders. These are equivalent to the above. Just a note at the bottom, multiple systems atrophy is a part of the synucleinopathies. It's a very different disease which presents with Parkinsonism, dysautonomia, sometimes cerebellar or spinal cord pathologies with less involvement of cognition. And it is when the synuclein accumulates in the glial cells. What is the pathology of this? So alpha-synuclein is a protein that we all have that does very important jobs. It is present within the lipid membrane, and it is encoded by this gene on chromosome 4, which sometimes has mutations, and this causes some of the genetic forms of Parkinson's. Normally, in a normal person, it has a tendency to aggregate. Some of these portions of the protein have the tendency to form into small groups called oligomers and dimers. But the problem is that when there is a disease, it accumulates way more. It is very prevalent in the hippocampus, thalamus, glia, and cerebellum. There are some variants of it that tend to make it aggregate less or more. And when it aggregates, the protein loses its shape and it can get truncated. And when you have a lot of aggregates, for example, you can see here how much alpha-synuclein is in the cytosol, so in the cell, in Lewy body diseases as opposed to control, and you see how much more there is. And the more you have, the more nerve toxicity or neuron toxicity and loss you have. And so since it's very expressed in these areas, you can cause with these aggregates loss of function in the acetylcholine system or acetylcholine producing system. So these patients are poor in acetylcholine, loss of dopamine, and other neurotransmitters are affected. And depending on where the loss is, you can have reduced memory and learning. You can have behavior, movement, mood, and cognition problems or other problems. When you talk about Parkinson's disease, which I abbreviated as PD, these Lewy bodies, which are the end result of the aggregation of alpha-synuclein with the toxicity and degeneration, are mostly subcortical, mostly in the basal ganglia. And that's why Parkinson's patients start with movement problems first and foremost. And then as the disease goes on, they can spread to other areas. And that's why some Parkinson's patients get cognitive issues, or most of them do. When it is dementia with Lewy bodies, for reasons we don't still fully understand, the Lewy bodies are cortical and widespread from the onset. And so that's why patients with this condition have a whole lot more cognitive issues in addition to potential Parkinsonism. And in multiple system atrophy, this aggregate is mostly in a different type of cell, which affects different structures. And you can see, under the microscope, how the various pathological changes of this appear in different parts of the brain. So we are going to switch gears a little bit to talk more about the clinical aspects. So when we talk about Lewy body dementias, which, as you remember, is an umbrella term that includes dementia with Lewy bodies and Parkinson's disease dementia, for both of them, the main clinical criterion is that there needs to be dementia. And if you remember when we spoke many times before about what is dementia, it means that there is a cognitive decline that is so bad that it's affecting one or more of the activities of daily living. It's not just based on the score on the MoCA, it's actually a functional change that the person has to have. Of course, there is a prodromal stage like in Alzheimer's, and that's the mild cognitive impairment related to Lewy bodies or to Parkinson's. And the important thing in making the right diagnosis is determining what the first symptom is. Sometimes you see patients after a while, especially with all the delays we have in healthcare. So with the patient and with the family, it's really important to understand what started first. If I met you 10 years ago, did you notice any changes then? And what were they? So take a little time to think about that, because if this person had clear motor changes for a year or more before the cognitive changes happen, as we said, it's PDD, Parkinson's disease dementia. If it is cognitive issues determining the dementia before or concurrently with the Parkinson's within that year time frame, then it's DLB. And now we're gonna zoom in a little bit more into DLB, which is the topic of the presentation. So for DLB, you need to look at what clinical presentation the patient is having, and the patient needs to meet certain core clinical features and potentially to help the diagnosis if some of the core clinical features are not present, certain supportive clinical features, which we'll go over in more detail. So dream enactment behavior, fluctuations, well-formed visual hallucinations, and Parkinsonism are the core clinical features. These, in studies with pathological correlates, have had the highest correlation to the pathology underlying. There are some supportive clinical features that can help you make the diagnosis if the patient doesn't meet the 2 or more core clinical criteria. So fluctuations, I start with that because it's the hardest to detect, even for me, because it's very vague, and patients sometimes and families are having a hard time really realizing that's existing. So fluctuation is determined as a spontaneous change or fluctuation in the level of alertness. It can be so bad that in some cases I've seen it resemble delirium, and I've seen it resemble seizures. And the epilepsy colleagues upstairs, I hope they don't resent me, but I do send a lot of EEGs when I have this suspicion. It's present in the vast majority of DLB patients, and the symptoms that are usually elicited are the person has staring into space all of a sudden, or a blank stare, or looking lost, or they cannot finish their sentences, or kind of feeling more confused for a period of time, and that is unpredictable. Unlike the sundowning of Alzheimer's, which typically happens at a predictable time of the day, or in response to being fatigued or sick, this is really a wild beast. It's unpredictable. It can be sometimes worse in the morning and sometimes worse in the afternoon. There are several scales available if you want it to be a little bit more accurate. And one of these is the Mayo Fluctuation Score. There is a newer one too. This is pretty simple where you can ask these few questions. And if you, every question is 1 point if positive. And so a score of 3 to 4 is more often present in DLB. Lower scores are more likely to represent AD. As a reason for the ups and downs. So this is not just good days and bad days. This is a little bit more specific than that. And then we have well-formed hallucinations. This is kind of self-explanatory. This is pretty common as well in DLB, 80% of patients. It's distinctive if it happens earlier in the course of the disease rather than later. Many patients with Alzheimer's, many patients with vascular dementia will eventually get hallucinations later in the course, but having specific types of hallucinations earlier is pretty important as a telltale signs. It can be preceded by these minor phenomenon, which are part of the supportive criteria. So seeing, for example, a shadow out of the corner of your eye, or feeling like somebody's behind you. This is called extracampine phenomenon. It doesn't count as a well-formed hallucination, but it can be a preceding subtle sign. Or sometimes people can have visual illusions. The most memorable are, oh, the trash can for the recycling outside looks like a small blue man. And then I look again and it's just a trash can. Or I see a person in the tree, but if I look closely, it's just a branch, you know. These are minor visual illusions. And so that just tells you, follow it up, because it could come into something bigger, which is well-formed visions of people, animals, monsters, things that are right in front of the person, that are well-formed and detailed. Having just one is not enough. They have to be repeated. Of course, if the person is sick and has them, that doesn't really count because that could be delirium. They're more common in women than in men, and more common in dementia with Lewy bodies compared to Parkinson's disease dementia. When people have Parkinson's and they're put on the Sinemet, which is the medicine for the movement problem, they can actually get more hallucinations. Parkinsonism, so in neurological terms, Parkinsonism is a specific presentation where people have slowness of movement and rigidity. Again, very common in DLB. Resting tremor is the thing we always think about when we think of Parkinson's. That pill rolling tremor is less common in DLB because you need a little more damage of the basal ganglia to get that mechanism rolling, no pun intended. This is a cause of disability, and there are some criteria to assess how disabled a person is. So the tendency to retropulsion predicts falls. So the pull test is something where you ask the patient to stay stable when you pull them from behind, and they can take 2 steps back, but no more than 2. If they're not able to hold themselves, you should really be aggressive with physical therapy, because that can help prevent some falls. Swallowing can become affected with Parkinsonism. Their tone of voice can become so low that they are not audible. And there are some rehabilitation efforts that can be done there. It is responsive usually to levodopa, carbidopa, which is Sinemet. Parkinson's is more responsive than dementia with Lewy bodies, is the usual experience we have. And then we have, as a last of the 4 core clinical criteria, this REM sleep behavior disorder, which also means acting out of dreams. Present in a little bit less patients with DLB, but it's very common. And physiologically, when we are in REM sleep, which is when we have dreams, our body is paralyzed. There is a specific mechanism in the pons that makes sure that there is not a lot of movements except some mild little jerking. So if I dream of flying off a roof, I will not hit my head. So it's an evolutionary process. In dementia with Lewy bodies, in synucleinopathies like these, that pontin mechanism is broken. And so during REM sleep, you will not have paralysis, also known as atonia. And so the person will act through their dreams, which are usually violent dreams for reasons we don't know. So punching, kicking, picking things out of thin air, like they're actually awake, but they're fully asleep. It usually happens when REM sleep is more prevalent, which is the later part of the night rather than the earlier part. Patients sometimes remember this, but by no means they are all remembering their dreams. And again, the physiologic twitches, a little bit of talking, or when you feel like you're falling immediately, when you're falling asleep or waking up, that does not count. That's a separate process. The interesting thing is that this is sometimes decades before the onset of the cognitive symptom. And about 75% and 90% of these patients that have REM sleep behavior disorder will eventually develop Lewy body disease of one form of, or Lewy body dementia, one form of another. The important thing is making sure that it's not secondary to other things to count it towards the clinical criteria. So certain most SSRIs and many SNRIs will cause acting out of dreams. So if the person has been on an SSRI or SNRI for the duration of these symptoms, we don't count it. We suspect it, but we don't count it. Sleep apnea can cause some of this. Alcohol, certain drugs can cause some of this. So it's important to rule out secondary causes. So then we've said there are supportive criteria, which are often present in a patient with dementia with Lewy bodies, but less specific to get you to the right diagnosis. The very serious one is sensitivity to antidopaminergics. We don't find this on purpose. We find this by accident. Never try this as a test. But sometimes patients will go to the hospital, and these patients, by definition, are more sensitive to delirium. They get Haldol to respond to delirium, and they all of a sudden get worse. That's a good sign that there is something going on in terms of synucleinopathy. And therefore, we avoid all typical antipsychotics like the plague in these patients. And I want to be very emphasizing this because it's really important. Once they get worse from this, they usually don't get better. And also you have an FDA black box warning on all atypical antipsychotics for all dementias, but especially for this. Autonomic dysfunction, very prevalent. And I don't have to teach you what that means because there's many primary doctors here, but usually blood pressure dropping when people stand up, especially with the summer, chronic long-standing constipation, urinary frequency, cold intolerance is something I see a lot. They were fine with temperature, and in the past few years, they're always cold, and they don't have any thyroid problems. Cardiac arrhythmia, there is a folk tale that said that many patients with DLB have a pacemaker years before the onset of disease. That's not been very well studied, but I see that quite a bit in some patients. And then those minor hallucinations and misperceptions that I've told you, especially later in the course, they can have delusions. People are trying to steal from me. People are coming to get me. There's people residing in the attic or downstairs, and I need to go check. And then mood problems are very prevalent before and during the disease. A little note on what testing we have in terms of biomarkers on how to help support the diagnosis clinically. When you do the cognitive examination, memory, if it is purely DLB, memory is usually spared. So their recall, especially with cues, is relatively intact. What they usually have is damage to the visual, spatial, and executive networks, those frontal and parietal networks. As time goes by, they can really have visual symptoms more prevalent, like spatial and depth perception, visual agnosia can become really evident. And then the motor features, I always say the first exam is the history of present illness. As you're observing the patient, they will have reduced blink rate. How do you know that? I get into a staring context with them. So I try to blink when they are blinking. And if my eyes hurt, that blink rate is way too low. So that's a good thing that you can do. Their facial expressions are reduced. Their voice may be very soft. And then you've got the more classic shuffling, stooped forward gait, reduced arm swing. It's a good thing, especially if they're reporting symptoms, to measure their orthostatic vital signs. And then some testing is available in terms of imaging. Supportive criteria on CT, or better still MRI. Usually the mesial temporal lobes, where the hippocampi are spared. Just like the memory is spared, the hippocampus tends to be spared if it is pure DLB. And then there is this classic sign where there can be hypometabolism in the medial temporal lobes, even if they're spared from atrophy perspective. And there can be general hypometabolism with sparing of the posterior cingulate. So we have that posterior cingulate island sign, meaning that it is usually spared. And I have some images to show you later. The EEG helps you understand, especially with a polysomnogram, that there is absence of, or whether or not there is absence of EMG sign during REM sleep. And these are supportive. The most important ones are, as I was saying, polysomnography can help you determine if you're uncertain whether somebody truly has REM sleep without atonia. Cardiac scintigraphy can look at the autonomic denervation of the heart. And then DAT scan can help show that there is reduction in that dopamine transporter uptake in the basal ganglia. So these are things that you can do. They're a little bit more advanced, but to try and confirm that those pathophysiological changes I was telling you about are actually there. There are newer biomarkers out there, which are great, but they're still very limited. They're very accurate, and they're moving us forward to a biomarker-based diagnosis, which is extremely helpful when the diagnosis is not clear. So there is a test on CSF, which is up to 89% accurate. They also have skin biopsies where they actually see that alpha-synuclein aggregate in the small nerves under the skin. Since there is an autonomic dysfunction, sometimes you see that in the peripheral nervous system as well. And that's, again, probably in tertiary care centers is available, or you can send them out to specific labs. These are the new things that are coming up. Some images to reinforce some of the tests we have. So you can see classic examples. Of course, real life is more complicated, but DLB, dementia with Lewy bodies, in the mesial temporal lobes resembles more normal controls than AD. Then you've got this DAT scan, where you see the basal ganglia and how much dopamine is available there. And you will see that it's pretty bright in normal controls and Alzheimer's disease, but it's pretty dark in DLB, and it's very dark in Parkinson's. So DLB and Parkinson's can be similar in that case. And then this is the posterior posterior cingulate island sign on the PET scan, where you see there is diffuse hypometabolism, but here you see a tiny blip of more activity when it is dementia with Lewy bodies. And otherwise, you see the parietal lobe dysfunction, the frontal lobe is a little bit less active than in normal controls. And you can see the difference that there is with Alzheimer's disease as to which areas are more affected. As I was telling you, the occipital lobe gets affected more in DLB than in AD in the earlier stages. This is showing the scintigraphy with the cardiac denervation. So the vagus nerve degenerates and it can leave the heart uncovered, and you see the difference in the normal control versus DLB. And this is a visual representation of REM sleep behavior disorder. So you have the EEG up here, and REM sleep is usually found with very large waves, and the person is dreaming with their eye movements, you know. And you see here the chin electrode, which tests, you know, the activity of the muscles. And in normal controls, it's pretty quiet, whereas in the DLB patient, it's very active. If they're in REM stage, they are not paralyzed as they should. So the revised criteria, putting all of this together, for probable DLB, which is a higher certainty stage, you must have dementia, and you have to have at least 2 or more of the core clinical features: fluctuations, hallucinations, acting out of dreams, and Parkinsonism. Or you can have one core feature with one of the indicative biomarkers that I've told you. Possible DLB is a lower certainty stage, meaning it could be, but you're not entirely certain. And it's only when you have partial evidence, or either you don't have the classic symptoms and you only have the biomarkers, or you don't have any of the core features. DLB is less likely if you have a clear other reason for it, if the patient is full of vascular disease. And so again, you know, if you have hallucinations in a dementia that's already advanced, that's a less specific sign. If similarly you have Parkinsonism in a dementia that's already advanced and the Parkinsonism is late onset, that's usually a less specific end result of many dementias. And so that is not as accurate. Management. So the bad news is that there is no cure and there is no FDA approved medication. And most of the cure or most of the treatments are aimed at palliation. The good news is that there is a lot that we can do in terms of trying to reduce some of the worst symptoms up to an extent. I think that starting off from this conception is helpful because it gives a more practical point of view to both the doctor and the patient. Like with Alzheimer's, the non-pharmacological interventions are very important, and I would dare say they're more important with this because the dopaminergic systems are really responsive to good exercise and cognitive training for that cognitive part. Structure during the day helps dementia with Lewy body patients incredibly. And having an educated, well-prepared caregiver is paramount so that they know how to respond to all the myriad of symptoms that these patients can have. And then we're going to talk a little bit more about the management for the various symptoms. For cognitive symptoms and most of the, or some of the hallucinations and psychiatric symptoms, first line that we do is cholinesterase inhibitors. So donepezil or rivastigmine. They improve cognitive and global functioning. Even when it feels like they're not doing anything, as long as the patient tolerates them, keep going because they can protect them from more rapid decline. We only treat threatening hallucinations. Some patients will say, oh, I see a little kid in front of me dancing in a nice dress and it looks like my granddaughter. Why would you take that away? So keep that. There's no reason to treat that if it doesn't bother the patient or doesn't cause anxiety. But for the more concerning or scary hallucinations, strangers, monsters, sudden animals showing up, donepezil or rivastigmine can actually reduce these phenomenon. And we usually try to use higher doses if the normal doses that we would use for Alzheimer's do not work, as long as their heart can take it and their stomach can take it. Memantine is less studied. I don't see a whole lot of benefit with that, but some people have noticed a little bit of improvement, but that's less important. Avoid antipsychotics as much as possible. I will try to think outside the box on every other possible type of thing before I give them even atypical antipsychotics. Sometimes your hand is forced. Sometimes there's no way that the hallucination can be treated otherwise. In that case, I prefer quetiapine because it has a less strong anti-D2 action as opposed to other atypicals like try to avoid as much as possible risperidone because that has a strong anti-D2 action. There is limited evidence from case report for quetiapine. There is no systematic study. And then pimavanserin is also known as Nuplazid, has been approved by the FDA for psychosis of Parkinson's disease dementia. And there has been a New England Journal of Medicine study in 2021 that it helps different other types of dementia, but FDA has not approved for DLB yet or other dementias. And so it's extremely expensive unless the insurance is understanding. Pimavanserin has some antipsychotic and pro-serotonergic actions. It's in between an antidepressant and an antipsychotic. And it's in the few patients I've managed to get it, it's really effective to reduce some of the worst psychosis and hallucinations. I also try to use sparingly with low doses SSRIs, buspirone, trazodone, and mirtazapine, because sometimes if you reduce the anxiety related to these hallucinations, they're not as bad or not as threatening. And then motor symptoms. Number one for DLB is aggressive PT and OT, regular exercise. And then there is this specific type of therapy, loud speech therapy, which helps them bring their tone of voice up when it's really bad hypophonia and help them with communication, monitor for dysphagia. These patients are more prone to fractures, so make sure their osteoporosis is well managed and their osteopenia is managed. Can try Sinemet. Parkinson's disease responds way better to Sinemet. The problem with DLB is you can precipitate psychosis and really bad hallucinations, which are usually worse than being slow with your movements. So I usually start in people who haven't had a lot of bad hallucinations, and I start very slow. I go like a turtle, I tell my patients, because this way, if something happens, you can dial it back immediately and they don't have full-blown psychosis. Deep brain stimulation, which is an approved treatment for Parkinson's, is not approved for dementia because it makes dementia worse. Dream enactment behavior, it can sometimes cause damage to the body or to the bed partner. So people can fall out of bed, can hit their arms. So the first line I usually do is melatonin. It can go all the way up to 20 milligrams, which is higher than most cases we use melatonin for. And it's pretty effective in restoring that reduced movement during sleep or making it less violent. Sometimes we use SSRIs. It's important to check that they're not making this worse. And then the second line is benzodiazepines like clonazepam. This can make confusion worse. So I usually reserve it for really severe, really danger-prone cases. Bed railings with pads can help avoid some of the damage. And unfortunately, sometimes the partner has to move out to a different bedroom to avoid getting bruised. autonomic symptoms, I'll breeze through this because you know what to do for the various things. Just be aware that these patients are prone to arrhythmias. And for urinary frequency, avoid anticholinergics because these patients, as we said, have a cholinergic deficit. If you block it even more, they'll get psychotic. And with that, I end my presentation, and I wanted to leave it up to questions. If not, I'll just go to my case.
Any questions for Dr. Russo? That was a fantastic overview. I particularly appreciated both the kind of the basic science, but really the pragmatic management tips. I like the staring contest too, in terms of matching the blink rate to see, to quantify what is sometimes otherwise hard to know. Is it too slow? Excellent tips.
I have a
Go for it.
I actually have a similar patient. I'm considering most likely DLB. Came into the Center for Healthy Aging yesterday. So looking at her case and trying to coordinate her care, I'm limiting imaging and stem-1 biopsy, really getting the most high yield studies at this time. I am sending this patient for DAT imaging. Is it ever the case when additional FDG PET may be useful in patients like this, if it's high likely, or do you recommend more of an algorithm, like which images you would get in order?
Yeah, so first of all, we mostly base this still as a clinical diagnosis. However, there are new guidelines in formulation where this may just be a biomarker diagnosis pretty soon. But still, we're in the clinical sphere. So if the patient meets at least 2 core clinical criteria, they have either dream enactment behavior not due to other things, well-formed hallucinations, Parkinsonism, and fluctuations, they have at least 2 of this, you meet probable DLB diagnosis. Assuming the Parkinsonism started, within a year of the dementia or after, if there is. I always do an MRI in patients to rule out vascular disease, microvascular changes, sometimes, or as I said, many times, especially if the person is older, Alzheimer's can be a co-pathology. And so you can have the symptoms of Alzheimer's, but you can also have variants of that pathology like cerebral amyloid angiopathy, which is basically when the blood vessels get weakened and you can get microhemorrhages, and that's a whole different disease that can cause intracranial bleeds. So the MRI helps also rule out this more rare consideration. So the MRI I do for everybody. And then if you have otherwise clear clinical criteria and the MRI doesn't show anything shocking, you shouldn't need any more testing. The DAT scan is something that I use if, I'm not quite sure if that is truly Parkinsonism. Or, if the person is a little bit slower, but it doesn't meet the full criteria of rigidity and bradykinesia. Or if they just have the classic example where DAT scan comes into play is they have a tremor that's an essential tremor, it's not a resting tremor, and you don't know what it is. If it is an essential tremor that hasn't gone into a synucleinopathy, then the DAT scan is completely negative. If it is an essential tremor, some people just start with essential tremor and then they become Parkinsonian. And you want to see if those basal ganglia structures are affected or not, then the DAT scan can help. The pitfall of the DAT scan is that you have to do it with a clinical background. because a positive DAT scan is not specific to synucleinopathy. It just tells you those basal ganglia are damaged. So you have to pick and choose. To give you an idea, if you do a DAT scan in a person who has vascular Parkinsonism, it will also show positive, most likely. Not always, but most likely. So I usually do it in those cases. I have an essential tremor. I cannot perceive for the life of me any Parkinsonism, or maybe their facial expressions are a little bit diminished. Sometimes dementia with Lewy bodies is like this, that you don't have the full-blown signs. And so that helps you a little bit along the way. The PET scan I do if, I have a completely normal MRI. And or the MRI is not telling me enough, and I want to see, are the mesial temporal, what is the pattern? What is the pattern of hypometabolism? And that posterior cingulate island sign is specific but not sensitive. So I use it when, again, the basic tests are not helping me. And so those ones are supportive because of that, because they are useful when the clinical features are not enough. Did I answer the question?
Yes, thank you so much.
Yeah.
Very good. I also see a question in the chat from Dr. Furies, who does not have a microphone, asking if you recommend primary care providers order PET or biomarker scans, any experience with any challenges with coverage?
Yeah, so the biomarkers, I'm sorry, I'm a nerd. And so when they came out, I was so excited because sometimes, as I said, there is a mild cognitive impairment stage of this, which will not meet all criteria by definition because it's not dementia. And yet you see these people, this usually happens with really high education people. You see their faces a little bit less expressive. They're maybe a little bit slower with their thinking. They have those extra camping visions, and they really want to know, they know that something is up, and they really want to know what's going to happen. You do a spinal tap, that's really usually accurate to confirm the diagnosis. If it's positive, you have made a diagnosis for them without waiting for clear, full clinical criteria. It is $1,000 out of pocket still. So it's not something that insurance is covering yet. It came out in 2021, and they said, oh, we're filing for insurance approval, but long is and arduous is the path of that. So unfortunately, that's something that they have to be willing to pay out of pocket. It was $1,500. They finally reduced it with the better SAA amplified to 1,000. You gotta have a specific kit, specific requisition materials. It's a pain. So I only do it in very select cases. Skin biopsies, they sell kits. There are some labs like C2N that send you kits and train you on how to do them. But if you miss the spot, and the synuclein is slightly next to it and not where you're putting it in, it's not as accurate. So I've never actually done them because I prefer to do a spinal tap, which allows me to also test for Alzheimer's and in some fast-moving cases, autoimmune diseases. I would say what I answer for Elif, if you have the clinical criteria, you could do a PET scan, again, if you don't meet the whole scenario and if you're not certain. PET scan is usually less accurate in mild cognitive impairment stage because you haven't, unfortunately, killed enough cells to show hypometabolism. Insurance has coverage issues sometimes with PET scan. I try to justify it from the point of view of this is important for the patient's prognosis. It determines some certain differences in management. And sometimes fighting enough, sending enough letters will finally have them concede. But for now, Medicare covers PET scans for differential between Alzheimer's and FTD, frontotemporal dementia, and DLB is not included. So there are these coverage issues. So yeah, you kind of have to work with it. And that's why I say, if you've got the clinical criteria, you don't need all of this. It's only when you don't have the full criteria that you need this.
Very good. I also see a comment in the chat from our own Karen Hayes, who is also without a microphone, kind of delineating the difference between the executive dysfunction that happens versus memory changes, and the difference between remembering episodic information or even semantic information versus sequences or how to do things.
Right. Yeah. So exactly, figuring things out is sometimes mistaken for memory loss. And so I tried, at first when I was in residency and they had me see this, I'm like, well, I tried to correct them, like, well, that's not memory loss. And they will look at me like I had 3 heads. So I would say I never correct them. I let them say it the way they think that that it is. But then I say, what do you mean by that? Can you give me an example? Well, he went to use the lawnmower and he forgot how to use it. That's not exactly memory from the hippocampus. That's more of a procedural task, or, if I tell him 3 things, he will only do 1 of them. Again, start thinking that maybe it's not memory, that it is an executive dysfunction, or he forgets where he's going. She forgets the direction to the grocery store or the doctor's office. That's visual spatial. And then when you test, again, MOCA tests are not great. I've done enough of them to hate them to my core. But when you do that, sometimes, not always, but you give them those 5 words, and they may have a lot of trouble recording it right away. That's more of an attentive executive function where they cannot hold those 5 items in their mind right now. And then if later on they don't remember it, it's not because the memory is affected, it's because the registration of it is affected. And I get it. Sometimes Alzheimer's also presents that way. But that's usually the difference, or their memory is intact. Or at the delayed recall, you give them cues and they right away get it, whereas the rest of the function is abysmal, then you see that there is a discrepancy. And you have to consider many of these patients have AD copathology. They like each other. So AD attracts DLB and DLB attracts AD. And so they're kind of toxic friends, so to speak. So sometimes you can have features of both. And so you are on the side of caution. If you think there is DLB together with AD, you try to be careful with how fast you change the drugs, avoid those antipsychotics. Maybe you can push the donepezil a little bit higher if they're having those clear hallucinations, etc.
Good. And a nice tip from Dr. Demotta Riley also, that indicating the differential between AD and FTD as considerations might help justify Medicare coverage for FTD PED.
Oh, cool.
Yeah, wisdom
Excellent.
hard won by experience.
Yeah, absolutely. I like that.
Yeah, I often just say, I mean, they're all sort of under consideration, and sometimes I will say, also Lewy body is under consideration so that the radiologist, is sort of looking for all 3 in the differential. But things are atypical enough. There's some executive dysfunction. There's some movement changes. So, and then often Alzheimer's is in the mix as well.
Absolutely, yeah, that's very helpful. Yeah, at a certain point, I'll say, if they really force me, I'll say, well, the person has executive dysfunction. Couldn't it be FTD? So unfortunately, they're not doctors. And so while we try to be very accurate, well, it cannot be FTD because A, B, and C, and D. But the insurance is not really an expert in this. And so if it is a frontal symptom, I also have to see what the frontal lobe is doing. So, yeah.
Wonderful discussion. Other questions, or Dr. Russo, do you think 15 minutes is enough to discuss your case and do it justice?
Yeah, absolutely. So this is a real life scenario where it's messy and it's not clean, and they present late. They presented really late. So this is now a 71-year-old right-handed female. She presented to me in 2023. They say the symptom onset was around 2022, but I suspect it was way earlier than that, and it wasn't maybe fully noticed. But around January, she had more memory changes, again, memory changes, difficulty remembering conversations, difficulties remembering events and dates, worse in the spring and summer. And again, that's what they're telling me is happening in 2023. And around that time, more trouble with multitasking, doing multiple things at once, concentrations. She had projects and tasks that she needed to do, volunteering and stuff, and she couldn't just get it finished, getting overwhelmed, anxious about anything, single thing that she needed to do. More in the summer of 2023, significant anxiety. And around this time, she started having hallucinations of strangers and people in the house, women in the backyard. Some days, better, I wanted to say better some days and worse on others, but no clear fluctuations within the day or for chunks of weeks at a time. And unfortunately, her husband passed away due to a serious health condition, and she couldn't be alone anymore. And she went to a memory care facility, and she was unable to remember that her husband passed away. And she kept on insisting on going to see her husband. And where is my husband? And at the memory facility, she thought that she was in charge, or that she was working for them, and she was trying to orchestrate everything for everybody. And so that led to a lot of clashing. In all of this, she let her insurance, or the family let her insurance lapse. And so she didn't have coverage. And so the doctor at the facility had to take care for some of her health and refills. And so she was lost to follow up. So you see how this is your classical messy scenario. A few things that pop up is that the initial thing was directions while driving, so that's not memory. That's usually, visual spatial or concentration. And then the multitasking, there are some memory changes here. It seems like it's decent memory changes. And then the anxiety and the hallucinations, all within, this concentrated time frame. Motor was fine at the beginning. As things progressed, her motor function started declining. So she's a little camptocormic now. I cannot see her in person because she gets really upset getting out of the facility. More help needed with medication since 2023. She started losing function mostly in 24 with the loss of her husband. And then sleep-wise, significant insomnia, occasional daytime somnolence, significantly acting out of dreams, moving arms and legs that her late husband could even tell me for years. And then by 2025, her ADLs have declined, but they were intact at presentation. Never had any major issues with alcohol or drugs. She's adopted, so we don't know her family history. Not a whole lot of other issues going on medically speaking. And this is her exam at presentation. Very thin, very anxious, couldn't sit still in the chair, distractible, couldn't finish her sentences. And her MoCA is pretty low. And again, I think this is a good example. It's 9 out of 30. Lots of points missed. You can see how abnormal her cube is. Look at her clock, Of course, you always grant the same number of 0 points because it's still abnormal. Other than the contour, she could draw the circle. But there is a difference between a patient that slightly misplaces the numbers and somebody who writes the numbers like this and just draws a hand. or somebody who just slightly misses the joining of the cube, and somebody that does this. So this is severe visual spatial dysfunction, couldn't really understand the trails. And then when you look at the memory, yes, she loses the 5 points, but she has a very poor registration. And so if you cannot pay attention on the spot, you cannot remember later on. So that is something that cued me, a little bit together with all the rest that I was hearing, that yes, I wouldn't be shocked if there is Alzheimer's here, but I don't think that Alzheimer's is justifying all of this unless it's an atypical Alzheimer's presentation. Especially the thing that also made me think maybe it's Alzheimer's a little bit is that the semantic fluency where you ask her to say animals was also pretty low. Similar to the phonemic fluency, normally you want to see a lot more animals than F words is my rule of thumb, to say that that part is relatively better than the other, and these are both low. Couldn't do world backwards, so spelling backwards is a type of executive dysfunction. And again, she deteriorated to the point that she was exit seeking at the clinic, so I could only see her on video, as her insurance allowed me to. And this is her MRI done before she came to see me. It's a little bit blurry because she was anxious, poor thing, to stay in there. But I try to put some relevant cuts. Maybe I missed the hippocampus a little bit, but you see her hippocampus is a little bit thin. There is a little bit of parietal dysfunction, or sorry, parietal atrophy. There's a little bit of white matter disease, this white that you see on the flare, T2 flare. And so you see, it's conceivable that there is some Alzheimer's. It's conceivable that there is some vascular disease, but it's the symptoms that are king here. There is something else that could justify this. We do a spinal tap, mostly because they were really swearing that this was a rapidly progressive presentation. And so I also have to rule out, as a neurologist, treatable things. Is this a paraneoplastic process or an autoimmune process? And thankfully it wasn't, but I had a scare, because the first thing that comes out is the Alzheimer's disease evaluation, usually, in addition to the first normal things that come out. And her A-beta, her amyloid protein, was within the low normal ranges, so already not consistent with clear full-blown Alzheimer's. Her tau was extremely high. This tells you full-blown neuron loss. And so you have to consider rapidly progressive forms of dementia. And thankfully, the autoimmune markers were negative. I also did prion disease in this case, and that was negative. This high 1433, which in the old days was used as a marker of prion disease, is just actually a non-specific marker, again, of neuron damage. And then the biomarker was positive. That solidifies the diagnosis, basically. And I cannot chalk it up to Alzheimer's anymore, because her amyloid should have been low. Maybe some processes microscopically of Alzheimer's are there, but not likely the cause of all of this. So the main discussion is that she meets the criteria, the core clinical criteria, possible fluctuations, but hard to define, but definitely she had the dream enactment behavior and the well-formed hallucinations. She's had numerous recurrent UTIs. She's getting frail. So we started her on the usual medications, and she's now on a rivastigmine. I don't know if I put it somewhere, but she's now on rivastigmine patch. She's on Lexapro to help control the anxiety. The doctor at the facility put her on quetiapine at night to help her with the anxiety at night, but she continues to have anxiety. So my plan is basically to try to optimize her, ancillary medications to try and reduce the anxiety about things like her husband or the delusions of working at the facility. I'm thinking of mirtazapine instead of trazodone. I've been trying to up the trazodone a little bit. As a last step, I'm going to increase the quetiapine if it continues to exacerbate. And if all else fails, I'm really going to push with insurance to try Nuplazid or pimavanserin. There is some report on the literature that says clozapine, but to do clozapine in a memory care facility with the risk of agranulocytosis is really dangerous, so I'm not considering that. And then I'm going to leave it open for any additional considerations, what has worked for you guys of the people on the meeting that deal with DLB, what have you found less effective, etc.
I gave it the requisite 20-second pause. I do want to make a plug for one piece, and I like the piece you have in there around training the staff for non-pharmacological interventions for leaders.
Yeah.
And I don't know if either Karen Clay or Karen Hayes has experience with this, but there's a wonderful book called Responsive Dementia Care. It was written with Lewy body and other dementias, but mostly Lewy body in mind. And I have heard over and over again from family care partners that it is super helpful. It's very pragmatic. It's very skills-based, kind of like when this happens, here's what you can try. And I would imagine this would be equally as helpful for staff at different senior living communities. There you go. The Caregiver Bible. There you go.
Nice.
I'll put the link in the chat.
Yeah, it's been a struggle to kind of get them, and I understand why. I mean, it's 1 person to 50 in there, but it's really been hard to get them to be responsive until the symptoms kind of are on the brink of disaster, or to get them to, address the UTIs. She's had 3 UTIs in the past 3 months. Have we looked at any physical reasons why this could happen? Of course, there is autonomic dysfunction, but is there something else? Is there a prolapse? I don't know. Can you please get it checked as much as possible? If she still has a lot of bacteria and leukocyte esterase after 7 days of treatment, maybe that's not the right antibiotic. So that's been kind of slow on the uptake. And in the setting of all of this, then the primary doctor there put her on valproic acid, which was even a bigger disaster. She got really agitated and combative. So then I have to trace my step back and say, well, we gotta take this off before adding more stuff. Do this and then let me know how this goes. And again, it's a good reminder for me because I have to tell them, please send an update. I haven't heard from you in about a month and I want to know. So it's kind of like in the setting of like the busy clinic where there's a lot of buzz, you have, like I have a list of VIPs. These are my VIPs. And I have to keep checking with them. But yeah, it's a work in progress where you have to be diplomatic. Because I couldn't do their job. And so why would I step in there and tell them you're doing the wrong thing? But at the same time, when it matters and the family is really concerned, you have to put your foot down or draw the line somewhere. So that's my kind of uphill battle. But if anything else that you found or any way that you have been successful in approving pimavanserin for these patients, because they always bring up the issue, it's not FDA approved for DLB, it's only for PDD. And I'm like, my friend, it's the same underlying pathology, but we'll do all the checks that are needed. But yeah, if everything fails, how have you been successful other than having them pay out of pocket, which they cannot do at this time?
Karen Clay, I saw you come off mute, and then I see Reza has a hand up also.
Yeah.
Hang on one second, Karen. I was eyeballing you first. I'll be right there with it.
Okay.
Yeah. I need to check out that book that you recommended. Another kind of free resource for family members on the Lewy Body Dementia Association website.
Yeah.
They do have some caregiver briefs that are kind of buried in there that can be hard to find, that basically lays out how to prevent symptoms, how to respond to them, specific things you can do. So I'll put that in the chat.
Thanks.
That's a free resource for
Yeah.
people.
Awesome resource. Thank you for that. All right, Reza.
I have a patient, she doesn't have basic Lewy body dementia, but she has Alzheimer's disease and frequently has urinary tract infection. They have a urine pad. It's hard to get a urine culture, urine sample from them. I
Right.
just treat this patient empirically with safe dinner for 5 days. And each time, delirium, everything is
Right.
going away after that. I just suggest to use maybe safe dinner for 5 days, see how she's doing.
Right.
That could be an
Empirically.
option.
Yeah.
And it
At a
doesn't
certain
hurt.
point. Yeah.
Yep. Thank you.
Absolutely. Thank you.
An excellent lecture. I learned a lot from you. Thanks a lot.
Thank you.
Well, we are at time. Dr. Russo, thank you again, both for the didactic, which was thorough and pragmatic, and the case, which is very real world. You're reminding me, our colleagues down at UCSF in their autopsy series, 98-99% of people with late onset dementia have 3 pathologies. Typically the ones that you have mentioned, and also true for our clinical core who come to autopsy here at the ADRC. Wonderful. And there's a reminder in the chat there from Sammy about CME. I will also remind you that you will receive an email shortly around CME as we are changing our kind of cadence for awarding CME for this series. It'll now coincide with the academic year, so July 1st. So in late June, you will receive some instructions about that. Thank you all for attending. Our next session, which is 3 weeks out, I believe, will be with our own fellow, Dr. Kalania Jimenez, on neuropsychiatric medications in dementia. It promises to be excellent. We'll hopefully see you back then. And hope you enjoy a long weekend if you have a long weekend, and a regular weekend if you have a regular weekend. See you next time.